Endodontic diagnosis. It's one of the most fundamental skills we have. But let's be honest, it can sometimes be really challenging. The whole point of this explainer is to give you a clear, systematic algorithm that you can take right to the chairside, something you can use immediately to make confident decisions for your patients. So, let's dive in.
I want you to think about endodontic diagnosis like you're solving a jigsaw puzzle. You just can't make a diagnosis from one single, isolated piece of information, right? The patient's history, the clinical exam, pulp testing, the x-rays, every single one is a critical clue. And it's only when we put them all together that we get to see the full picture.
So here's our roadmap for solving this puzzle. We're going to start by gathering clues from the patient. Then we'll get to the really critical part, the pulp vitality test. From there, we'll check out the surrounding tissues and decode our radiographs. And finally, and this is so important, we'll talk about what to do when the pieces just don't seem to fit.
Okay, first things first. Before you even think about touching the tooth with a test, we have to lay the groundwork. This is our information gathering phase, and it is the absolute foundation of the entire diagnostic process. You can't skip this.
And we have to follow a very specific sequence. We always start with the medical and dental history. Then we listen, and I mean really listen, to the patient's chief complaint. After that, we do a thorough clinical exam, checking everything, soft tissues, periostatus, the works. It's only after those first 3 steps are done that we even move on to clinical testing and finally the x-rays. See how each step builds on the last? It's systematic.
All right, now we're at our first major fork in the road. Pulp vitality testing, and specifically the cold test, is our #1 tool for figuring out the health of the pulp. This one test is going to set us on one of 2 very different diagnostic paths.
The entire diagnosis at this stage really hinges on one single question. The way that pulp responds to a cold stimulus tells us a massive amount about what's going on inside that tooth. It's truly our most reliable way of listening to what the tooth is trying to tell us.
So, what does a healthy, normal response look like? Well, for a normal pulp, the patient's going to feel a mild or transient sensation that just disappears almost immediately. We're talking 1 to 2 seconds after you take the cold away. And here's a pro tip, something you absolutely must do. Always test adjacent teeth and the contralateral tooth, the same tooth on the other side first. This gives you the patient's unique baseline for what a normal response feels like for them.
Now on the flip side, here is the key diagnostic sign for irreversible pulpitis. Lingering pain. This is the big one. If the patient gets a sharp pain that just hangs around for 30 seconds or even longer after that stimulus is gone, that pulp is inflamed beyond its ability to heal itself. This is a definitive sign that endodontic treatment is needed.
Let's just put these two side by side to make it crystal clear. With a normal pulp, you've got a mild, fleeting response. It's there, then it's gone. With irreversible pulpitis, you're looking at sharp, lingering pain that can even be spontaneous, and it's often so bad that over-the-counter painkillers do absolutely nothing. If you remember one thing, remember this: the duration of the pain is the single most reliable clinical sign to tell these two apart.
Okay, so we've established our pulpal diagnosis. Great. Now we need to figure out if that inflammation has spread beyond the tooth itself and gotten into the surrounding periopical tissues.
And you know what? The tools we use for this are wonderfully simple, but they're incredibly effective. We use percussion, just gently tapping on the biting surface of the tooth, and palpation, where we apply some firm pressure to the gums right over the root apex. If the patient feels pain with either of these tests, that tells you there's inflammation in the periodontal ligament space. This brings us to 2 main apical diagnoses. First, symptomatic apical periodontitis. It's exactly what it sounds like. The patient has symptoms, pain when they bite or when you tap on the tooth. The inflammation is active. And here's a key radiographic finding. You may or may not see any changes on the x-ray yet. But with asymptomatic apical periodontitis, the patient has 0 clinical symptoms, no pain at all. But when you look at the radiograph, you clearly see a dark area, a radiolucency at the apex. It's a chronic, quiet process of bone destruction. Now, what if the tooth doesn't respond to our pulp tests at all? No feeling whatsoever. This leads us to a diagnosis of pulp necrosis. It simply means the pulp tissue inside that tooth has died. But listen, there is a huge, and I mean huge, caveat here. A diagnosis of necrosis is only valid if your control teeth, those neighboring and contralateral teeth, respond normally. If a patient doesn't respond to cold on any of their teeth, then your test is totally inconclusive. A no-response finding means absolutely nothing without the context of a normal response from other teeth. Don't fall into that trap. All right, let's move on to our final diagnostic tool,
the radiographs. These are essential for correlating what we found clinically with actual physical evidence of changes in the bone. They help us confirm what our hands and our tests have already started to tell us. So, one diagnosis that can be a little tricky is the chronic apical abscess. Why? Because it's often asymptomatic, a lot like asymptomatic apical periodontitis. But it has one very unique and definitive clinical sign that gives it away. And this is the key right here. The hallmark, the dead giveaway, of a chronic apical abscess is a draining sinus tract. You know, that little pimple you sometimes see on the gums? The definitive diagnostic test, you gently insert a gutta-percha cone into that tract until it stops, and then you take an x-ray. That cone will literally point you directly to the apex of the offending tooth. It confirms the source of the infection with 100% certainty, no guesswork needed.
So we have to talk about this. What do we do in those really challenging cases where the findings just don't add up? The patient has pain, but you can't reproduce it. The pulp test says one thing, but the radiograph seems to be saying something completely different.
Okay, so what's the protocol? Rule number 1 is simple. Do not, under any circumstances, start treatment without a probable diagnosis. Sometimes the best and the safest thing you can do is just wait. Have the patient come back in a week or two, see if the symptoms localize. Document everything, especially your uncertainty, and explain it to the patient. And most importantly, if you are ever in doubt, do not hesitate to refer to an endodontist. And that really brings us to our final takeaway. Being a great diagnostician isn't just about always having the right answer. It's about knowing when you don't have enough information to proceed safely. So when those puzzle pieces just won't fit, what's your next step? Remembering that a referral is your best move is what protects your patient, protects your practice, and ultimately, it ensures the best possible outcome for everyone.